Okay, this is lecture 3 for unit 7 on capnography, and we're going to talk about each one of these things that you evaluate when you're interpreting different graphs. Again, their height, contour, baseline, frequency, and rhythm. So the height or peak, this indicates the end tidal CO2 value, which is point D on the graph represented below there. Because the partial pressure of end tidal carbon dioxide in healthy individuals closely approximates the partial pressure of arterial carbon dioxide, this measure is potentially useful non-invasive index of the adequacy of ventilation. So instead of having to draw blood gases all the time, we can use capnography as a trending tool to see if the carbon dioxide levels are increasing or decreasing over a period of time. The contour normally should have a sharp upstroke, so this point from B to C should be a sharp upstroke. It should have a plateau, which is that C to D, and then it should have a rapid downstroke, which is D to E. Conditions such as COPD, pulmonary emboli, and low perfusion states caused by shock or left ventricular failure may all decrease perfusion to ventilated areas of the lung, and that will raise the VQ ratio, and it will also alter the expired CO2 waveform. So changes in the waveform can also occur with equipment malfunction. So if you don't see the sharp upstroke, plateau, and sharp downstroke, then it's either equipment malfunction or they may have some sort of VQ ratio causing disease or condition. The next one is baseline. It indicates inspired carbon dioxide. Normally should be 0 because we don't inspire that much carbon dioxide. Remember, it's just 0.03% carbon dioxide in atmospheric air. So the baseline, it should always return back down to 0. Anything elevated indicates that you're rebreathing carbon dioxide. So either, again, we're not allowing the patient enough time to exhale, causing that baseline to be up higher than 0. And we just need to do some things with our IE ratios. Frequency and rhythm corresponds to the frequency rhythm established by either the patient if they're spontaneously breathing or the respiratory rate that we have set on the ventilator. So another way of saying frequency and rhythm is respiratory rate. So how well does our end tidal CO2 compare with our partial pressure of arterial carbon dioxide? Normally they should be within about 5 to 6 torr of each other. So any PA CO2 minus end tidal CO2 higher than 5 to 6 torr is abnormal. Mechanical ventilation does increase our VQ ratio, which can increase the PA CO2 minus PE CO2 to as high as 15 torr. Some problem solving or troubleshooting. The most common problem is contamination or obstruction by secretions or condensation. So this happens on a pretty frequent basis. So regular changing of sample tubing or cleaning of the chamber, which is that little sensor that's in between the endotracheal tube and the ventilator circuit, with alcohol. Between patients, clean with a high-level disinfectant, and they do need to be sterilized before using on the next patient. If you're getting an inaccurate reading with high respiratory rates, this is more of a problem with the side stream capnometer because, again, they're taking some flow out of the ventilator and reading it up there, and so it can't keep up with high respiratory rates. Misinterpreting low or absent cardiac output as a disconnect or possible esophageal intubation, because all three can result in an end tidal CO2 of 0. So you always need to look at your patient. So if you're getting an end tidal CO2 reading of 0, look to see, is it really a patient problem, such as cardiac output issues or esophageal intubation, or are you simply disconnected from the ventilator and you just need to reconnect them? So again, always look at your patient first. The difference between PaCO2 and partial pressure of end tidal CO2, if the difference between those two widens, so if you take your PaCO2 minus your PeCO2 and you get a large number, then the patient's pulmonary perfusion is decreasing. and that would indicate a pulmonary emboli. So you want to really highlight, star that area. The boards will do that to you. They'll give you a difference between PaCO2 and end-tidal CO2 will be a very large number when you subtract those two numbers. And then you would want to decide that that patient probably has a pulmonary emboli. So that's the end of the lecture for Unit 7. You can look at this very short, I think it's only a minute long, capnography demonstration if you want, but I would highly recommend the 7 video tutorials that are on Brightspace. Those would be found under Content, Unit 7 video links. They do a much better job than this 1-minute demonstration does on going through the different capnographs. So if you go into the PowerPoint and you click on this link here, you'll be able to get to that 1-minute video. But again, there's 7 videos that are under Unit 7 in the content area. Again, you go to Content, Unit 7 video links, and you'll be able to watch 7 different videos on capnography. Again, I highly suggest that you watch those videos. There is good information, and he does a pretty good job of explaining different things. And it's easy to see that because he does have it connected to a ventilator. So if you have any questions, go ahead and put those in the discussion area, or you can email those to me. Again, I will also try to get some sort of Zoom lecture that we can do live for this unit and try that out as well. So I hope everyone is staying healthy and safe, and I hope you have a great day.